Good evening to everyone present here with us today. This is Shreyan from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker doctor for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Anirban Vishwas. Sir is consultant neurologist, director of neurology, Institute of Neuroscience, Kolkata, founder of Vertigo and Deafness Clinic, Kolkata. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is physician approach to a patient of vertigo. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Okay. Uh, Good late afternoon, or rather, good evening, everybody. Let's start here. First is that let me introduce myself as I'm not a neurologist, I am a neuro-otologist. That means my practice is limited to vertigo and deafness only. And that is what I have been doing for the last nearly 37, 38 years. Practicing only on vertigo and related disorders, and definitely hearing disorders, tinnitus, then deafness, etc. But then basic practice is related to vertigo. Now, coming to a step-by-step approach to vertigo in a physician's clinic, the most physicians see a huge lot of vertigo patients. Vertigo patients will be about 7% of all patients that visit a ENT doctor or a neurologist's clinic, or 2% of all patients that visits a physician's clinic. So it's a pretty large number. Now, how do you go to a step-by-step approach in vertigo? We first need to elicit the history. A very detailed and a thorough history taking, which is a pretty time-consuming job, is step number one. Without a thorough history, you cannot ever treat or diagnose a patient of vertigo. There are numerous investigations. There are a lot of clinical tests that can be done, but everything is irrelevant until you have a very thorough history and know the patient's symptoms, how the patient presented, and what are the patient's problems. You have to know that very well. And if you can take the history properly, that should help you in diagnosing more than 85% of the patients. If you do the clinical tests properly, you should be able to diagnose more than 95% of the patients. Only about, say, 2-3% patients at most will require investigations, and about 1% of patients will still be there whom you will not be able to diagnose. So, what are the steps of diagnosis? First is eliciting a very thorough history. Next is examining the patient clinically, then investigations if necessary, then to treat the patient sensibly. Because when we come to treatment, we'll tell you treatment has to be done sensibly, and then restoring normalcy means bringing the patient back to mainstream, where the patient will not have any vertigo, any instability, or any balance related disorders. Okay, so we go by steps one by one. Now, the physician's job is number one. First job is identifying the sinister causes of vertigo. Some patients of vertigo will be coming to you. Do not take them very lightly. It is a head spinning. It may be a stroke in the posterior fossa. It can be a sign. Vertigo can be the only sign of a stroke in the posterior fossa. It can be the only sign of an acoustic neuroma, which is a tumor in the brain. It can be due to trivial causes like vestibular neuritis. It can be due to diseases like Meniere's disease. But as a physician, your job is to identify the sinister causes of vertigo and imbalance. Which patient is in a bad shape, that you need to know and identify beforehand. Otherwise, you'll be in serious trouble. So, step number one in this is identifying the sinister causes of vertigo imbalance. Next is ruling out non-vestibular causes that mimic vertigo. There will be a lot of patients who come to you with symptoms like panic attacks or orthostatic hypotension. If you ask them why they've come to you, they'll tell you, I get chakkar. हमरा चक्कर आता है, আমার মাথা ঘোরে, I get attacks of dizziness, but then actually it is in many cases nothing but a panic attack, or it can be something like an orthostatic hypotension, which most of your physicians and you know that much better than me. Okay, so after you ruled out the sinister causes of vertigo, the next step is to rule out non-vestibular causes that mimic vertigo. It may not be any vestibular disorder. Remember that. Then diagnosing the site of the lesion and the nature of the pathology. That means you have to know whether the problem, if it is vertigo, then you will have to know whether it is due to some problem in the brain or in the ear or in the eyes or in the proprioceptors. So diagnosing the site of the lesion and the nature of the pathology. And once you've been able to diagnose the site of the lesion, say you know it is the ear, then you will have to find out whether it's Meniere's disease or vestibular neuritis or perilymph fistula or something like that. If it is in the brain, you will have to know whether it's an acoustic neuroma, whether it is a cerebellar tumor, whether it is cerebralitis, whether it is Parkinsonism, whether it is multiple sclerosis, so on and so forth. Then, after you have been able to diagnose the site of the lesion and the nature of the pathology, the next step is treating the causative pathology with exact disease specific therapy. That means if it is a positional vertigo, BPPV, that patient will not require any medication. That can be corrected only by the liberatory maneuvers, nothing else. No medicine is required for positional vertigo. If it is Meniere's disease, you have to treat the patient with steroids, with diuretics. If it is vestibular neuritis, you'll have to treat the patient with steroids. If it is an acoustic neuroma, it will have to the patient will have to be subjected to surgery or whatever it is. So you see, depending upon the cause, if it's a vestibular migraine, then the patient will require migraine prophylactic therapy, etc. Then providing symptomatic relief without camouflaging the symptom of vertigo. See, this is something very important. When the patient has come to you with acute vertigo, the patient is severely distressed mentally and physically, and the patient is vomiting, patient is in bad shape. So it is imperative that you give some symptomatic relief to the patient, and that is only possible by some vestibular sedatives. But remember, there is a big catch in this. It is best to avoid vestibular sedatives as much as practicable because the vestibular sedatives jeopardize the vestibular compensatory mechanism, which prevents the patient coming back to mainstream. And these patients, who treat them for a prolonged period with vestibular sedatives, then they remain imbalanced throughout life. Their head spinning can come down, but giving the patient drugs like beta histine, cinnarizine, prochlorperazine, etc., for a long time jeopardizes their balance, and the patient becomes unstable and unsteady. So that is why you have to be very, very careful and very conservative when you are giving the vestibular sedatives like beta histine, cinnarizine, dimenhydrinate, meclizine, prochlorperazine, etc. So that is one thing you'll have to be very careful about. You have to give some symptomatic relief, but with a lot of discretion, trying to not to use it as much as possible. So that is a catchy situation. Then treating the comorbidities. Most of these patients presenting you with vertigo will have comorbidities like depression, anxiety, etc. So that cognitive problems, so that needs to be corrected. That needs to be treated along with the vertigo. And lastly is restoring balance. Restoring balance, and that is possible only by physical therapy, not by any medicines or nothing or anything else. These are the different steps. First, identify sinister causes of vertigo, then rule out the non-vestibular causes that mimic vertigo, then diagnose the site of the lesion and the nature of the pathology, then treat the causative pathology with disease-specific therapy, as I said, then provide symptomatic relief without camouflaging the symptom of vertigo and with a lot of restraint and with a lot of discretion, because all the anti-vertigo drugs are dangerous drugs, and they not only have a lot of side effects, but another problem is that they can jeopardize the vestibular compensatory mechanism, which in effect actually restores the patient's balance. So you have to be very careful when providing symptomatic relief. then treating the comorbidities, and lastly, restoring balance, which is possible only by physical therapy. Okay. Now, approach to the patient. When the patient comes to you, first find out, does this patient really have a disorder in the vestibular system, or it is a case of orthostatic hypotension, neurocardiogenic syncope, or an acute pyramidal disorder, or a panic attack. Because this is all these patients, when they come to you, they'll come and tell you, Hamara chakkar aata hai, that I get vertigo. But actually, they are got nothing to do with the vestibular system. So we first have to rule out things like these, which are non-vestibular causes of vertigo. The what is orthostatic hypotension? In orthostatic hypotension, there will be an abrupt fall of blood pressure on sudden standing, sinking sensation, blurring of vision, blackouts, but no loss of consciousness. So that is called orthostatic hypotension. Take a history of the drugs that the patient is taking, because mostly orthostatic hypotension occurs as a adverse effect of certain drugs. So that you have to know. Maybe the patient has taken the antihypertensive twice on that day, more than what is but the patients is, a lot of the patients forget, and so they can take a antihypertensive more than they are scheduled to take. So that can be there. So you have to ask the patient, what are you having? Are we having a spinning? Patient will say no. Ask them, are you having a sinking sensation? Are you getting a blurring of vision? Are you getting a blackout? Then you know that it is something but orthostatic hypotension. Because a blurring of vision or blackout will never happen in vertigo. Then, if you know that orthostatic hypotension, good enough. Then you have to rule out neurocardiogenic syncope. What is a neurocardiogenic syncope? In a neurocardiogenic syncope, there'll be it happens due to inadequate blood supply to the brain. There'll be a loss of consciousness and fall when when standing up or getting up from the sitting position. The patient will say that I was standing in a line for a long time in the sun, and suddenly I do not know what happened. I found that I'm lying on the floor and people are sprinkling water on me. So that is neurocardiogenic syncope. There will be loss of consciousness with fall. So that happens due to inadequate supply of blood to the brain. Then there can be something like an extrapyramidal, acute extrapyramidal disorder. Involuntary movements, repetitive or sustained contraction of muscles, there will be muscle twitching, tremor, dystonia, involuntary muscle contractions causing repetitive or twisting movements. The patient will make different grimaces, bend the head sometime, or you find that the patient's head or the arm is bent in a peculiar way. So these patients, they have they have movement disorders, and when they come to you, or they may be having tremor. So you see, these things, when you have to see and recognize them, they've got nothing to do with head spin. Then it can be a panic attack. And what is the panic attack? Panic attack is extremely common, and all these panic attack patients, when they come to you, they'll tell you that hamara chakkar aata hai, I get vertigo. What is a panic attack? You have to be see, if you are physicians, I have no locus standi in teaching you what is a panic attack and what is a extrapyramidal disorder, or what is an orthostatic hypotension. But you say, I believe we are talking to a mixed audience, and so we go into a little bit of details so that anybody can diagnose these patients very well. What is a panic attack? A panic attack is a phase of heightened anxiety. It is an acute anxiety attack with features and a feeling of something awfully catastrophic is about to happen, and the thought of impending death, and the patient responds to it by a fight or flight response. So the symptoms will be shortness of breath, choking or tightening sensation in the throat, chest pain, nausea or stomach discomfort, dizziness, feeling of losing control over the body, an impending pain, palpitations, a thumping inside the chest. These will be there. So you have to talk to the patient, and if you find that the patient is an anxiety prone person, and that the patient was having some anxiety at that time, and the patient you see, if you talk to the patient, you'll be able to understand whether this is an anxiety prone patient or not. Or if you cannot do it, there are questionnaires downloadable from the net, which is called the HADS, Hospital Anxiety Depression Score. Make the patient fill it up, you'll know whether there is anxiety. So if the symptoms are there in the patient, then you will know that it is a panic attack and it is not a vertigo. If it's a panic attack, the best drugs to treat it with will be basically the benzodiazepines like clonazepam, then the SSRIs, etc. Especially a drug like clonazepam usually suffices in most cases. So if all these are ruled out, there is a possibility that there is a disorder in the vestibular system. Then what do you do? Then we test the vestibular system. But before going to that, what I had told you, identifying the sinister ones. That means which ones are dangerous. So there will be some signs and some symptoms by which you will be able to diagnose that whether it is a dangerous thing or not. If you see this video, I keep on playing this video for a long time just to impress upon you that vertigo can sometimes be due to life-threatening conditions also. If you see this video, you'll remember it that the patient had come to you only with vertigo, but it turned out to be a posterior fossa stroke, and the patient became unconscious, or it was something like that. So, what symptoms are dangerous and what signs are dangerous? These are the dangerous symptoms, the red flags. If there is some central nervous system symptom like severe headache, diplopia, motor or sensory disturbance, loss of consciousness or drowsiness, be careful. It can be a sign of a sinister cause, life threatening cause of vertigo. If there are oral symptoms like deafness, tinnitus, and fullness, it can be something like Meniere's disease, which is not life threatening but extremely traumatic to the patient. If there is instability and not vertigo, that also is a dangerous sign. It can be an indication of a tumor in the brain. If there is vertigo lasting for more than 4 weeks, it is also a dangerous symptom. If there is a gradually deteriorating vertigo, then that is also dangerous because vertigo usually is, in most cases, peripheral causes of vertigo are self-limiting. Within a few hours' time or maximum a couple of days at the most, the vertigo goes away by itself. So if but instead of that, if it goes on deteriorating and increasing, it means there is some sinister problem happening inside the brain. What are the dangerous signs? One is a vertical nystagmus or any abnormal eye movement, which is not plain horizontal nystagmus. Horizontal nystagmus is not dangerous, but any vertical nystagmus is always dangerous. Skew deviation of the eyes. If you look at the patient's eyes and you find that one eye is at a higher level than the other, it is called a skew deviation. So that is again dangerous. Then there can be a motor or sensory loss or any other central nervous system signs like plantar extension, then deep tendon reflexes, hyperreflexia of the deep tendon reflexes, or unsteadiness which is out of proportion to vertigo. These are all dangerous signs. And Hinge test, which is a specific test, if that is positive, then that can also be we do not have the time to go into the hinge test now, but a hinge test will help you determine when a patient of vertigo comes to you, acute vertigo comes to you, whether it is a harmless thing like a vestibular neuritis, which is a self-limiting disease, or it is something due to a stroke in the posterior fossa, which is a dangerous thing. So you see, these are the symptoms and signs where you should be very careful and think that it can be due to some dangerous disease. So some red flags to be aware of in patients presenting with vertigo. All physicians have to keep these red flags in mind. If the patient comes to you with severe headache, severe sudden onset headache along with vertigo, remember that there is a 40% chance of it being a stroke in the posterior circulation. Migrainous vertigo will also present with headache, but that headache will not be so severe. And moreover, it can be migrainous vertigo, but the patient will have a past history of headaches also. But if there is no past history of headaches and the patient has come to with sudden severe vertigo, head spinning with some amount of instability and severe headache, it is possibly a cerebrovascular accident, maybe a hemorrhage in the posterior fossa. If there is gait ataxia, it may be the only sign of a cerebral stroke initially. If there is gait ataxia, that means when the patient is coming into your clinic and see people are holding on to the patient, that means the patient cannot even stand erect, cannot even walk 2 steps. It is a dangerous sign. You know that it is possibly a case of sudden onset of gait ataxia is to be taken as a posterior fossa stroke if not proved otherwise. Then very sudden onset, possibly of vascular origin, may be a severe. I was cooking at home and suddenly everything started suddenly so severely spinning that I fell down. So that can be a very sudden severe onset. It can be a vascular origin, like a cerebrovascular accident. If there is vertigo with hearing loss, do not think that just vertigo with hearing loss is due to Meniere's disease or labyrinthitis, which is a peripheral disorder. It can be labyrinthitis, definitely, but it can also be a stroke in the supply region of the anterior inferior cerebellar artery. If it is an ICA stroke, the patient will have vertigo along with the hearing loss. Just because the hearing loss is there, do not think that it cannot be a central cause. It can be a central cause also. So never undermine the possibility of a cerebellar stroke in all patients of acute vertigo. Keep that in mind. That if there is headache, if there is gait ataxia, if there is very sudden onset, or if there is vertigo with hearing loss, remember it can be a cerebellar stroke, and so be extremely careful when seeing that patient. Now, what are the common causes? Common emergency causes by which when a physician is called in. A patient is having acute vertigo, what can be the causes? In 30% of the cases, it will be BPPV, which there is no medicine for positional vertigo. The patient will come and tell you that I could not get up from bed. As soon as I was trying to get up from bed, I was falling behind. If I'm turning towards one side, I'm feeling severe giddiness. When I'm lying down in bed, I'm getting severe giddiness. If something falls on the floor and I try to pick it up, I get severe giddiness. Each giddiness will be for less than half a minute. And then after that, it will subside. So that is BPPV. So BPPV is 30% of all vertigo patients. And BPPV does not require medication. It can be corrected by a maneuver. And all physicians must be competent in learning this, hone the skills of doing these maneuvers, because by doing the maneuver, you can cure the patient then and there immediately in your clinic. And it is so very gratifying not only to the patient but also to the doctor that it is worth learning the different positional maneuvers by which you can correct the BPPV. Then that is 30% of the cases. 25% will be non-vestibular causes. That means syncope, orthostatic hypotension, panic attack, psychogenic vertigo, anxiety, etc. So that will be 25% of the cases. Then migrainous vertigo, that means migraine presenting with vertigo. That will be 20%. Do not think that each and every patient of migraines vertigo will have to have a headache. About 50% of them will have a history of headaches. In other 50%, there may not be any headaches at all. So that is also something. You will have to know that, because this is one of the common causes. Then it can be vestibular neuritis, which is an inflammation of the vestibular nerve. That happens in 15% of the cases. It can be something like labyrinthitis. That happens in about say 5% cases. Meniere's disease about say 5% cases or lesser. Then stroke, about 2 to 3% cases will be stroke. Mane a stroke in the posterior fossa. So when the patient of acute vertigo comes to you, these are the common causes by which the patient has developed the acute vertigo. Okay, so these are the, if you remember the treatment of BPPV, be careful to rule out the non-vestibular causes like syncope, orthostatic hypotension, panic attack, psychogenic vertigo, anxiety. If you are able to diagnose migrainous vertigo, which one is vestibular neuritis, which one is labyrinthitis, which one is Meniere's disease, and which one is stroke, your job is more or less done. So it's not a very big thing, and this is easy for any physician to pick it up perfectly. Now, how to approach to the patient? See, when the patient comes to you saying of acute vertigo, there are certain things that you need. The first thing to do is that test for postural blood pressure and blood sugar. Most physicians will have the BP instrument and the glucometer. It can be a hypoglycemia for which the patient has come to completing a vertigo, or it can be postural hypotension. That means there has been a orthostatic hypotension, something like that. Check the arterial saturation and the pulse. Then, if you have the facilities, do an EEG with a carotid massage. That is very important. But if you are doing the carotid massage with the EEG, ensure that the patient is lying down in bed and you have at least an oxygen cylinder or some measures to resuscitate the patient. The patient gets resuscitated by itself only, but when you are doing the carotid massage, never try to do it with the patient in the sitting posture. You have to do the cerebellar test and the basic neurological examination to rule out any stroke or anything. So these are the things that you need to do when the patient has come to you. The first, do not think about vertigo. First, do these basic checkups, and this is completely a physician's job. And for that, I need not tell you the importance of these things. You are all physicians, and you must be very adept with these things, and you will realize the importance of doing these things. Then, so keep in mind the possibilities of a presyncope or hypoglycemia, presyncope and hypoglycemia, dehydration or hypovolemia, a pulmonary embolism. That is why we ask for the arterial saturation and pulse rate, pulmonary embolism, then cardiac dysrhythmias, need to see the pulse, cerebellar stroke, and lateral medullary syndrome. You see, these things you have to keep in mind whenever the patient is coming to you with acute vertigo. When these things have been ruled out and you know that your patient is safe and you will not be unsafe, then you go to the next step. So the next step is the hinge test. It is a combination of three tests: the head impulse test, the test for nystagmus, and the test for skew. There is one eye is at a higher level than the other eye. Now these videos are over there, but I don't think we'll have the time to cover these things, and we will not go into these videos, things like this. If any of you are interested, let me know. I will send you the videos of these different things. Then once this is done, diagnosing the patient. It is done by history taking, by the clinical test and investigations. What are these history taking? Is first you will have to distinguish whether it's vertigo, that is head spinning, whether it is dizziness that the patient is feeling dizzy, that means the surroundings, there is no rotation, but patient feels that I am stable, but my surroundings are not very stable. That is called dizziness. Dizziness is defined as spatial disorientation. That means you are not fitting into the surrounding space very well. Unsteadiness is imbalance, and sinking sensation is what happens in syncope. You get a sinking sensation as if you are slowly sinking and immediately you will faint. So these are different sensations. So, and each has got a different meaning. We'll come to that now. That is, if the patient says, my room is spinning, my head is whirling, what does it mean? It means that that is actually vertigo. And it is so in this patient that you will need a careful neurological and an otological examination. There is a high possibility of this being a vestibular disease. So you go on those lines and investigate the patient for the vestibular disorder. But which patient, when the patient comes and tells you that I'm getting a chakkar, things are moving, this room is spinning, my head is whirling, then you think about a vestibular disorder. If the patient comes and tells you that I might fall, I am feeling imbalance, I can't stand without support, it's a completely different entity. It means that there is disequilibrium and unsteadiness, and this is not vertigo. This is unsteadiness or disequilibrium. Careful neurological and a complete physical examination is necessary in these patients. It is a non-vestibular neurological disorder or non-vestibular non-neurological disorder. Also, like a patient of syncope will also come and tell you something like this. Then, if the patient is saying that I am dizzy, dizzy means chakkar aata hai. Do you think things moving? No. I feel that I am not stable. I may fall. I may fall, and the surroundings do not appear stable to me. I am. I have a fear of falling. I feel lightheaded, or I feel a heaviness in the head. I am always feeling dizzy. But are you think things are moving, spinning around? No, there is no rotatory feeling. So that is another category. This is lightheadedness or unsteadiness or dizziness and a fear of fall. Exclude organic diseases, that has to be done, and if organic diseases like orthostatic hypotension and panic attacks, or say these things have been ruled out, then think about a psychiatric or a psychological disease. These patients are very difficult to deal with. If the patient says that I might faint, I am sinking, and I get blackouts, is a pre-syncope or a syncope. There a cardiac examination, a test for orthostatic hypotension, and a head-up tiltable test is necessary. What is the test for orthostatic hypertension? You ask the patient to lie in bed for 30 minutes, and then in the lying down position, the patient tests the blood pressure. Then the blood pressure is tested. Then the patient suddenly stands up, and again the blood pressure is tested. Then the patient keeps on standing without holding on to something, and you test the blood pressure after 3 minutes, after 6 minutes, after 10 minutes. And you see if the blood pressure, the systolic falls by 20 or more, or if the diastolic falls by 10 or more, then it is indicative of a orthostatic hypotension. In these patients, a head-up tiltable test is essential. Now, you have some important questions in history taking. First question is to ask is, how often do you get the attacks of vertigo? A single attack or multiple attacks? A single attack can be stroke, it can be labyrinthitis, it can be a vestibular neuritis, it can be a transient ischemic attack, or it can be a trauma or a labyrinthine conclusion. In that, there will be one attack. The patient will not give a history of previous attacks. If there are multiple attacks, you are having the vertigo for the seventh time. It can be a Meniere's disease, it can be a vestibular migraine, it can be a chronic recurrent vestibulopathy, it can be a BPPV, it can be a superior semicircular canal dehiscence, it can be a vascular insufficiency, or it can be multiple sclerosis also. So just by seeing whether it's a single or multiple attacks, you can have a good idea. Then you ask the patient how long does each episode of vertigo persist. That is the duration. If it is for a few moments, it can be a poor vestibulocular reflex. If it is for a few seconds, it can be BPPV, it can be orthostatic hypotension, or it can be a vestibular paroxysmia. That means neurovascular compression. If it persists for a few minutes, it can be a transient ischemic attack. It can be a vestibular migraine. It can be a perilymph fistula. It can be a superior semicircular canal dehiscence. If it is persisting for minutes to hours, it can be a Meniere's disease. It can be a vertiginous migraine. It can be labyrinthitis. It can be a posterior fossa stroke. If it is there for a few days continuously, it can be a vestibular neuritis. It can be vestibular migraine, or it can be a recurrent vestibulopathy. If it is there for a few weeks, it is usually psychogenic or something of a central nervous system disorder, most commonly cerebellar disorder or an extrapyramidal disorder. If it is there for months to years, it can be a psychogenic vertigo or a central nervous system disorder. So that goes about this. Now, to also ask what was the provoking factor. If there is any altered head position is causing it, that means when I'm getting up from bed, when I'm lying down in bed, when I'm turning on the side, I'm getting it. It is BPPV. If it is a sudden, if it occurs on suddenly standing up from sitting position or on prolonged standing, it is orthostatic hypotension. If neck extension is causing it, then it can be a vertebrovascular insufficiency. If stress is inducing it, it can be a psychiatric vertigo or psychogenic vertigo or functional dizziness, or it can be a vertiginous migraine. If changes in the air pressure is causing it, it can be a perilymph fistula or a superior semicircular canal dehiscence. Changes in the air pressure means if somebody puts the head puts the palm over here, or there's a loud sound that is causing the giddiness, then it can be perilymph fistula or a superior semicircular canal dehiscence. If there is headache, it can be due to vestibular migraine or vertiginous migraine, same thing. You also have to ask the patient as a physician, what medicines are you currently taking? Many medicines cause vertigo and dizziness, which is the commonest side effect of most medicines. Then you ask, are there any metabolic disorders like diabetes, thyroid disorders, lipid metabolism disorder? These can also cause disorders in balance. So ask the patient if there is any psychological disorder, depression, anxiety, schizophrenia. These patients can present with vertigo very commonly. Panic attacks is one of the commonest manifestations, and any family history. Then you have to test for the different ataxias. Blood tests are all now available by which the familial ataxias can be ruled out. So, when you know the nature of the symptom, the duration of the symptoms, whether it's single or multiple attacks, what is the precipitating factor, and what are the accompanying factors, when you churn them up, then you can reach a very definite diagnosis. So, that is how you come to a definite diagnosis only from the history. Now, after you've taken the history, you have to do certain clinical tests. And what are these clinical tests? The Unterberger stepping test, the head impulse test, the test for any nystagmus or any abnormal eye movement, the positioning test, the test for skew deviation, the Romberg's test, and the standing test. So these are the basic tests that each and every patient of vertigo has to undergo. And in the physician's clinic, these tests have to be carried out in every patient of vertigo. There is no time to go into the discussion of these tests, show you videos. Do we have videos of these things over here? But then time is a constraint. And the other tests that are required are the oculomotor test, the basic neurological test, and the cerebellar test. All these things, the procedures and these tests, they are present in my website, vertigoclinic.in. If you go there, the videos of most of these tests are there. Okay. So these are the different tests, the underbar stepping test, head impulse test, videos of these tests are there. But I don't think you have the energy now to see it, or we have, the time will also be a constraint. And from 6 o'clock, most of your clinics will start. And so by before 6 o'clock, we'll have to finish. Okay. So we are not going into going into all these details. But you see, certain things like, and let me just show you one thing. This is the test for positioning test. We do this test, we make the patient suddenly sit up, lie down, then, so, sorry. So there are different types of tests that we do. So these are all the different types of tests, and we find out whether the patient is having this positioning test, just to show you one. Anyway, then investigations. If there is a symptom of hearing loss or tinnitus, then you have to ask the patient to have the audiological test like PTA, pure tonodimetry, BERA, and ECOG done. If there is unsteadiness, imbalance, or ataxia, very sudden onset of vertigo, then definitely do a brain MRI, if required an MRI angiogram, and test like NCV. NCV means nerve conduction velocity, and the somatosensory evoked potential. If there is unsteadiness, imbalance, or ataxia, then these investigations are indicated. If the symptom is of head spinning, then the vestibular function test, especially VNG, VHIT, subjective visual vertigo, WEMP, dynamic visual acuity, posturography, all these things have to be done. You see, depending upon what the patient's symptom is, you will have to advise what investigations are to be done. And this advising for investigations has to be done at the physician's level only. For this, you do not need to send the patient to an ENT doctor or to a neurologist. You are capable enough of differentiating between them and advising the requisite tests. Now, there are specific tests for each part of the vestibular organ. This will be just to tell you that each part of the vestibular system can be tested, and we can give you a very precise diagnosis. Like the lateral semicircular canal of the left side is 39.68% defective, or the saccule in the balance organ is 82.6% defective. So that is the precision that we have. So that is just to tell you. So for each part of the vestibular labyrinth, there are different tests, and from each test, you can find out which part is at fault. Now, treatment. This is the last part of my presentation. In about 5-7 minutes time, we'll finish the treatment. So we'll finish in about 45 minutes. We'll try to keep finish in about say 45-47 minutes, so that we have about 10 minutes time for question answers, if any. Treatment in today's perspective, the first thing is that provide symptomatic relief in case of acute head spinning, taking care of the inherent ill effects of the anti-vertigo drugs. All the anti-vertigo drugs have severe inherent ill effects. They have got too much of adverse effects, and secondly, they jeopardize the vestibular compensatory mechanism. Keeping this in mind, you have to be very conservative and very discriminatory in prescribing the vestibular sedatives. Then, once this has been done, you have given some symptomatic relief to the patient, diagnose the cause of the vertigo and treat the cause of the vertigo rather than merely suppress and camouflage the symptom of vertigo. This is the second thing. Then, third thing is treat the comorbidities, especially the psychological and the cognitive impact of the balance disorder, and lastly is restore the deranged balance, which is possible only by physical therapy. So you see, this is what is there about the treatment. The symptomatic relief, then diagnosing the cause and giving medicines specific for the disease, like steroids in vestibular neuritis, diuretics in Meniere's disease, like that, and treating the comorbidities, like treating the patient with benzodiazepines or SSRIs, depending upon, or cognitive enhancers like ginkgo biloba or donepezil, like that, and restoring the balance by physical therapy. So this is what treatment is all about. So the current consensus of treatment is never to continue the vestibular suppressants or antivertigo drugs for more than 3 to 5 days at a stretch. Maximum, we try to limit it to 1 day only. So whenever you are prescribing a drug like beta histine or sinerizine or prochlorperazine or meclizine, try to limit it to 1 day only. In fact, we usually nowadays try to limit it to one dose only, because the symptoms come down, and the best part of the vestibular compensatory mechanism takes place in the first few hours after the acute vertigo. So we do not want the patient TNS to be suppressed at that time, and a little bit of vertigo will further stimulate the brain to develop the vestibular compensatory mechanism. So that is why the current consensus of treatment is never to continue the vestibular suppressants or anti-vertigo drugs for more than 3 to 5 days. Forget 3 to 5 days, not more than 1 day. See, it's medically, morally, ethically, and scientifically irrational and irrational to continue prescribing an anti-vertigo drug for an indefinite period. So this is the common trend in medical practice. We get prescriptions every day of different doctors prescribing drugs like prochlorperazine, Vertin, and Vertin is this beta-histine and sinerizine for weeks and months together. This is ridiculous and criminal. This should not be done. So this is what the current textbook teaching is, that the current consensus is that drugs exerting a sedative effect on the vestibular system should be used only for the first 24 hours, not more than that. And this is from a book which is more than 25 years old. Nowadays, it is there everywhere that you cannot give a vestibular sedative for more than 24 hours. So, and more than 95% of the patients of vertigo imbalance are due to BPPV or these things. So, and for each of them, you have got very specific therapies. So it is not that you have to keep on camouflaging the symptom of vertigo or keep the patient on vestibular sedative. You diagnose the underlying cause which is there, and after you diagnose the underlying cause, give the disease specific therapy. So specific therapies exist for all of them, and none require a long continued non-specific therapy with the anti-vertigo drugs. Like vestibular seizures are treated by anti-epileptic drugs. Vestibular paroxysma is treated by carbamazepine. Labyrinthitis is treated by antibiotics, antivirals, and steroids. Meniere's disease is treated with diuretics. Vestibular neuritis is treated with steroids. Psychogenic vertigo is treated by SSRIs and benzodiazepines. Vertiginous migraine is treated by migraine prophylactics, and BPPV is treated by the liberatory maneuvers. So, see, for everything, there's a very specific treatment, and there's no necessity of you are going on giving the antibiotic drugs for months and weeks and months and years together. So the comorbidities will also have to be treated. Now, see, the next part is about the different drugs. I don't think we'll go into the different drugs. We have taken 45 minutes. If you have any specific questions on any drug, then I will answer that. Because otherwise we'll not have time. 45 minutes if we have already taken, and this is this. If you think that you need to ask any drug, I'll go back and tell you about that drug. Okay, so would the lady from ICJP, Shion, please take over from now and tell me what next.
Sure, sir. So, sir, we do have some question from our audience. If you like
Yeah,
to
tell
take
me.
that up. Yeah. So, sir, the first question is, what key information should patient with vertigo be provided regarding their condition, treatment option, and self-management strategies?
Okay. See, you have to tell the patient, number one, is that what information the patient has to get. The patient has to be clearly explained whether it is a disease in the vestibular labyrinth, that means that the balance organ is at fault, or the brain is at fault, or it is basically a psychological disorder, or it is something which has got nothing to do with the balance system, like it is an orthostatic hypotension, or yes, that disease part will have to be explained to the patient. Remember one thing, that if you are not explaining the disease part to the patient and you're prescribing certain drugs, the patient goes home and immediately searches the net to find out about the drug and why you have given, and if the patient is not convinced, the patient is not going to come back to you. So you have to explain to the patient, and it is not always possible that you will be able to diagnose in the first go itself. So tell the patient that this is what I am thinking. Your thing can be a vestibular disorder, it can be due to this. So we are need to investigate and find out. You try with this medicine first. We'll get some symptomatic relief, and on the basis of that, we'll find out how you are keeping. Do investigations and find out. Give them the roadmap that this is how you are going to progress. You'll also have to explain to the patient the need for not taking anti-vertigo drugs for a long time, because vertigo, if I do not know if any of you have ever had it, or anybody in your family has had it and they have seen, it is the most traumatic experience in a patient in anybody's life. Getting a vertigo, it is not only physically traumatic, it is mentally traumatic also. So the patients want to continue with the anti-vertigo drug. They think that just because they've taken the Vertin or the Stemetil or the Stugeron, their vertigo is there. It is not like that. Vertigo is a manifestation usually of a peripheral disorder, and peripheral disorders are usually self-limiting. They go away by themselves. If not in a few minutes, then in a few hours. If not in a few hours, then a couple of days can recur. That we'll see later on. But it is that has to be explained very well to the patient. Regarding the drugs, you have to teach the patient that you cannot continue with the vestibular sedatives for a very very long time. So that is all, and also you need to impress upon the patient the necessity of vestibular exercises, which has to start from day one. In the day one, you cannot ask the patient to do the dancing exercises, but you can tell the patient that you sit in bed and do the eye exercises and the different exercises. There are exercises, all exercises are there in my website, vertigoclinic.in. You can see the exercises over there. You can extend those exercises to your patients also. You can give them the link. They can download the exercises, the print form of the exercises are there, the videos of the exercises are there, and they can start doing the exercises. But you have to impress upon them that they are not to continue taking the anti-vertigo drugs for long. Anyway, next.
Next question is, sir, how do you tailor vestibular rehabilitation exercise to individual patient?
How do you do the vestibular exercise in?
To individual patients, sir.
Oh, see, like treatment for every patient, medical treatment for every patient is tailored according to the patient's necessity, and it is customized according to the disease and age, sex, mental condition, everything of the patient. Similarly, all physical therapy is also customized according to the patient's requirement. Like if my tests tell me that there is a defect in the saccule. Saccule is the part of the ear, of the inner ear, which senses up down movement. This movement, up down movement, front back movement, side to side movement, that is tested. That is sensed by the saccule. So if my tests tell me that this patient's saccule is 62% defective, then what do I do? I need to stimulate the saccule. And to stimulate the saccule, what do I do? I make the patient go up and down, up and down. How do I make the patient go up and down? See, we in our clinic, we have got a special hydraulic chair which goes up and down slowly. Then we have in our clinic also gym ball type of a thing in which the patient sits, and that is a mid frequency stimulation for up and down movement. Then we have special things by which we can move the patient side to side also. And when the patient is comfortable with this, then we make the patient jump on a trampoline for high frequency stimulation of the circuit. See, you see, depending upon what is wrong, we stimulate that part. Supposing we find that the lateral semicircular canal is defective, then we make the patient do movements like this, which will stimulate the lateral semicircular canal. We ask the patient to look at a point, and we ask the patient to do things like this. If I know that the right anterior canal is defective, so this is situated like this, we'll ask the patient to do a movement like this, looking at a point. So, see, depending upon what part of the balance organ is defective, we tailor and customize the exercise accordingly. You can ask me one thing that, so there are these tearaway sheets called the Cotton-Cook's exercise. See, they are not specific. They are one size fits all, and it does not work like that. And moreover, the Cotton-Cook's exercises which is available in those tearaway sheets, they actually have no meaning. These Cotton-Cook's exercises were introduced during the Second World War for rehabilitation of war victims who were injured in the war. That time, nothing, that was in 1945, means nearly 80 years, 85 years back. At that time, nothing more much was known about the anatomy and physiology of the balance system. So that those exercise effort, they improve the balance, general balance in a little bit. But nowadays, when our investigative modalities and our treatment facilities are so refined, you need refined, customized, and tailor-made investigations for all your patients. Good question. That is something which I did not cover in my in my presentation. Thank you for asking this.
Thank you, sir. So there is one last question.
Yeah, please.
How do you interpret the result of vestibular function test, and how do they influence management decision?
See, well, now you have put me in a difficult situation now. The reason is, in our day-to-day practice, we actually do not need the vestibular investigations very much. If I have been able to take the history very thoroughly, I've done the clinical tests very thoroughly, that is more than enough in more than 95% of the patients. Very few patients will require the vestibular function test. Now, even if you do the vestibular function test and it tells you have done most of these tests are wrongly done. They are done by third parties, and they are done by the doctor practically never does it. It is usually done by third parties who do not have any idea about the vestibular system. So most of these tests are erroneously done with a lot of procedural errors. Now, supposing for the sake of argument, we think that okay, one test has been properly done, and you know that this patient has got you've done a perfect VNG, which 1 in 100 will be perfect, most will be wrong. You have been able to do a perfectly proper VNG, and the VNG test has told you that there is a 67% canal paresis on the right lateral canal. That is all the information you will be getting. Now, if you know that there is a 67% canal paresis in the right lateral canal, how is it going to help you in your therapy? Because that right lateral canal's paresis can be due to Meniere's disease, it can be due to an acoustic neuroma, it can be due to vestibular neuritis, it can be due to labyrinthitis, it can be due to a procedural error because the technician had not put the water into the ear properly. There could have been some wax inside the ear. So there are numerous reasons. There could be a multiple sclerosis on the vestibular nerve which has caused this. So there are numerous reasons. So the tests are not going to tell you the reason for it. If you do not know the reason, how will you treat it? If you are having a high-end vestibular physiotherapy setup like the types we have, because we are in practice of vertigo only, so that is all that we know, and that is all that we do. So in a very sophisticated clinic like ours, there we have got the facilities of stimulating each separate canal. You can the VHIT will tell you whether the anterior superior canal and anterior canal of the right side is defective, or the posterior canal of the left side is defective, whether the superior vestibular nerve is defective. So then we have special ways for stimulating only the anterior canal or only the lateral canal, only the utricle or only the sacral for specific setups. You need specific, so that will be help, but not the medical treatment. So knowing it, doing all the investigations, but every Tom, Dick, and head that comes to you actually is senseless. They do not help you. You have to acquire the skills and hone the skills of taking a very perfect, thorough history and the clinical tests.
Thank you,
If
sir.
you have
And
any questions, you can always email me and ask me. You go to our websites. I'll be more than happy to answer whatever queries you have. See, in this 1 hour that we have spent over here, it's too short a time to give you a complete flavor of what this science is all about. But this is a very interesting science which combines the musculoskeletal system, the psychic system, the cognitive system, the visual system, the labyrinthine system, the central and peripheral nervous system. Everything together combines together to give you this sense of balance. So there will be a lots of questions and lots of things. Okay, so I believe we have exceeded time and there is nothing more but now yeah, please take over.
sir, we have one more question, and that is the
Yes.
last question, sir. What are the treatment options available for marine disease, and what is the evidence supporting their use?
Now, repeat the question once again. What is the treatment options available for?
Marina disease, and what is the evidence supporting their use?
No, which disease? What is the name of the disease you said?
Sir, let me just spell it out for you. I also can't get it. It's MENIERE.
I'm not getting you. What? M E?
MENIERE.
I said Meniere's disease.
Yes, sir.
Yeah, Meniere's disease. Okay. See, Meniere's disease, the only treatment that helps is giving the patient diuretics because fluid has collected inside the inner ear and that can only be drained by diuretics and nothing else. Though there is a huge scientific propaganda and advertisement of beta histine, it has been proven by very authentic studies that beta histine is nothing more than a placebo. If you want the thing, there is a freely downloadable article. A article was published in 2016 December in the British Medical Journal, where a multicentric a controlled study was done by giving beta histine to three groups of patients: placebo to one group, 48 milligrams per day to one group, and 144 milligrams per day to one group. And they were followed up for 9 months. It was found that there is no change in any of the groups. So the patients given placebo and the patients given 144 milligram and the patients given 48 milligrams all had the same results. And we know now that beta-histine actually has got no scientific evidence to show that it is there. Moreover, beta-histine is a drug which has got a very high fast pass effect. That means it gets destroyed before it reaches the site of the site of action. It is called a fast pass effect. It does not help. So though it is promoted very much, but in for treatment of meningitis, the only treatment that is logical and therapy and actually helps is diuretics. If diuretics do not work, then we try with intratympanic gentamicin. That helps. If intratympanic gentamicin also fails in the rare cases, the rarest of rare cases, then we go in for selective vestibular neurectomy. And which diuretic? We usually use drugs like hydrochlorothiazide, spironolactone, acetazolamide. These are the drugs that we mainly use. You have to be, when you are giving a diuretic, you must be very careful to check the blood pressure and the serum electrolyte levels very regularly, because they, in some patients it can cause an electrolyte imbalance, so that has to be checked. But that does not mean that you will not prescribe the diuretic. Okay.
Thank you, sir. Thank you for answering all our questions. That's all from our audience, sir. So, sir, before concluding, any last remark from you? Sir, I hope I'm audible to you.
Yeah, yeah.
Yes. So, sir, what I was saying, sir, we are at the end of our session, sir. So, I'm asking for any take home message from your end.
Any?
Take home message for our audience.
Uh, See, the thing is that as a one-liner, I would say that we must first understand that vestibular sedatives have to be abhorred. They are to be used as less as possible. We must stress more on history taking and clinical examination rather than on investigations and disease-specific therapy. If it is Meniere's disease, treated with diuretics. If it is vestibular neuritis, treated with steroid. If it's vestibular migraine, treated with migraine prophylactics. That, and lastly is start the vestibular exercises as fast as possible, always from day one, and as soon as the patient can do. If the patient cannot sit up or even, then lying down in bed, ask them to do the eye movement exercises, and also the main cornerstone, mainstay of therapy to restore balance is exercises. So we, you cannot undermine that, and forget those tear away sheet exercises. We will have to try to diagnose what it is and then treat the, and prescribe medicines according to the positive lesion, and also therapy tailored according to the patient's findings. Thank you.
Thank you, sir. Thank you so much for joining us today, sir. And with your permission, sir, I would like to conclude today's session. Thank you.